Alright guys, I like having Billy Bones here. Still working on the name. Actually, you're going to be Billy Jean today because we're talking about hysterectomies. Because I know exactly where to put my head if I have the camera facing the other direction. We're about the same height, right? Yeah. It's a bit of a strange topic today. My wife's going to let me know if my mic's working. But, yes, post-operative pain after getting hysterectomy. So, drew a little uterus here for you. So we'll talk about that, and we'll talk about some of the various causes that we might have. The mic is good. All right. Thank you, Alex. Everyone say thank you, Alex. But let's show you the pelvic floor before we get into this, because the pelvic floor isn't drawn on here, and the pelvic floor has a lot to do with this. And if you have a pelvic floor and you don't have a uterus, or you're a male, you still have a pelvic floor. I didn't know if people knew that. But this video can benefit all of you. So let's zoom in on these pelvic floor muscles so you can see them. Zooming in. All right. So pubic bone, so that's the front there. You want to think about it that way. So we have these muscles, and you're like thinking to yourself, this looks like a diaphragm. You should be thinking like it is a diaphragm. So it's a breathing. It controls pressure in the body, and we'll get back to that and that idea. But essentially, pelvic floor muscles, you have your sacrum bone. Sorry, moving the camera. I need to see too. Sacrum bone, I'll look through the camera. Sacrum attaching bottom, so it's called the apex of the sacrum, where it joins that coccyx bone. That's where the pelvic floor muscles are attaching. And then we have bladder in the front, we have the vagina, then we have the rectum, all attaching to the pubic bone here. But then you'll notice there's these muscles, this wall on the outside, not considered the pelvic floor. I've conveniently drawn the iliopsoas in here, so we'll get to that later. But muscles like the piriformis, the obturator internus, and the coccygeus muscle are muscles that the pelvic floor attaches to. So you can think about, okay, our hip, so I kind of drew the hip here, and we'll get to that later, being retroverted or anteverted, can tug and distort the pelvic floor by pulling one way over the other. All right, so we'll get back. Actually, we'll just drop this out of the way here if I can detach that. Now I'm gonna need both hands here. We'll put you down for a second. Gonna be patient with me today. All right, we'll get that one. I'll come back to that chart. But let's do some Bob Ross drawings here. So blue, we're gonna use blue to mark some of the ligaments, and we can't really cover all of them. And I don't really want to go in detail on this surgery for you, but some of the ones they cut during this surgery. And there's a couple different ways they'll do this surgery. The most classic is to actually go up in through the vagina. So they'll sever this whole muscular part here, suck the uterus off. But first, and chiropractors know this one here. We'll mark it in blue. Probably not exactly, but we can see it's a little higher, more towards the base than the apex. So the pelvic floor is below these ligaments, and that's important for this first idea, which is destabilization of the pelvis, where a reliance is put on the muscles, the pelvic floor, to do the job that possibly these uterine type stabilizing ligaments do. Because most of you are like, oh, they just suspend, right? So we have the cardinal ligaments off here, kind of our fallopian tubes in the way there, but you can kind of see how they, they're in the front, they're in the back, they're in the sides. We have our round ligaments coming down. You have the broad ligament, which mostly just holds the fallopian tube, the ovary, to the main uterus body. But we have this structure we're kind of seeing enveloped here. So all these have to be taken out to remove this uterus. So we think about, okay, these are all holding. And if you ever watch my video on the forced closure of the sacroiliac joint, we're saying, okay, well, if you remove these SI joints where the sacrum meets the ilium can be pulled apart or just be less stable. And then our pelvic floor has to do more work, and the slings of the body that we talk about in that video, the oblique slings and the longitudinal sling have to do more work. That thoracolumbar fascia can get tight, and there's probably already had a problem there already. And we'll probably hit those points as we move. So that's number one there. We'll back up a little bit. So we have to take those ligaments out, we have to cut them, can destabilize the pelvis. Hypotonia, it just means lack of tone, right? So maybe they are already weak. Remember, the pelvic floor muscles are down below. Maybe they're already weak due to lack of use, or they've gone in and possibly, you know, there's all these nerves here, these holes in the sacrum. Actually, we'll go over here to Phil. Sorry, you're not Phil anymore. You're Billy. Billy Jean. We see the nerves, right? So a lot of nerves there, nerve roots. Then we have local nerves very close to what needs to be cut, especially that sacrouterine ligament, which attaches to the sacrum. Could be cut, could be damaged, could be nicked, could take time, could be just general inflammation, irritation, sitting on these nerves, causing damage over time. Doesn't have to be something that's actually cut. So we could blame maybe the doctor on that one, or just there was already a problem, which could be a number 5 on here. Let's say, like, okay, there was endometriosis, maybe due to just tension and irritation on these ligaments over time, you know, because they're susceptible to that. If there's some sort of irritation over time chemically, there's distortion. You have one hip that's turned in or out, it's distorting the pelvic floor, it's distorting the pelvic structure. You have more pressure on one over the other. Not a big problem in a short amount of time, but you take decades, put that on there. That creates this twisting over time, and then imbalance in muscles, more tension, irritation on the ligament, disease sets in. That's how it works. Number 3, inflammation, irritating nerves and muscles. So we just had a major surgery done. A lot of cutting was done. There's inflammation there. It's going to irritate the nerves, which is going to mess with the muscles. And it's kind of like when you're sick, and or I have a fever, I'll feel like injuries that I haven't felt in a long time, like when I separated my AC joint, or I'll feel low back pain. It's just all this inflammation in your body. It's kind of bringing about imbalances you don't notice on the day-to-day. They're there. We're all imbalanced. I see so many people laying on my table. The legs aren't even. They're twisted. It's typical, right? It's not normal. It's typical. You see it a lot. And they don't really know it. They don't really feel it. And same with like the spine. We'll say, like, you know, if we look over here at Billie Jean again, they can have a lot of arthritis, degeneration in the spine, and they'll see it on the x-ray, but they won't really notice that they had any back pain at all. Maybe they're in for knee pain, they're in for some sort of sciatica pain, but they didn't really notice that this degeneration had crept in. So ligaments are like that. They sense motion, they're good at mechanoreception, not so much at nociception. All right, number 4, so damage to the pelvic floor. Remember, pelvic floor kind of, you know, let's get our other chart back, but we have the vaginal opening and the pelvic floor wrapping around it, so it's possible that some damage was done to the pelvic floor muscles, and that can create instability or imbalance as well. And we'll talk about the exercises and how the hips work here. So let's go to red. So red is muscle. So I'll put my blue pen down here, put you all down for a second. It's gonna be the most shaky cam video I've ever done. So blue, we're doing ligaments. Red will be muscle. We mentioned them before, we showed them on the chart, now I'll show them here. So this top one, this is your piriformis muscle. So this is what's called your trochanter. It's part of your femur, and it's on the backside. So remember, this pelvis is facing us, right? There's your pubic bone. If you can actually find that bone that sticks out, like if you're washing dishes, we'll use this analogy again later. Washing dishes, your pelvic bone wants to rest against there, and that's, you know, where you always get wet from washing dishes. Or that's how I get anyways, and I'm always reminding myself to pull that pelvic bone back because it has a lot to do with the pelvic floor, because the pelvic floor attaches to that pubic bone. So let's follow piriformis out here. So it attaches to your sacrum, and it creates one of those walls around this pelvic floor that we saw. You know, the walls just a cup, you know, make sure the organs don't fall through. So there can be holes in our pelvic floor. So no direct attachment. There's probably fascial attachment to the pelvic floor from the piriformis. It's the one that goes in here. So it covers the obturator. And you can see it kind of drew it in pencil here so I can remember how it went. But that's this other tendon going to the hip. So you're like, obturator internus, that must internally rotate the hip. It doesn't, sorry. It is another external rotator. We'll talk about the inhale and what that does to the hips and what most people's patterns are and how that inhale actually destabilizes the pelvis as well. And then get this ischial spine right here. That's that coccygeus muscle, which you can figure out goes to the coccyx, right? Based on the name. So we'll have this tendinous sheath here where the pelvic floor attaches to these two muscles, the coccygeus and that obturator internus. So we can see if that hip is rotating, how it's going to tug and distort the pelvic floor one way or the other. Some people, both hips are externally rotated, or just maybe one over the other. It's rare that somebody has like a double anteversion problem. It's not typically what we see in our first world culture. We'll talk a little bit why that is. So I know that was a little rough on the drawing there, but hopefully that helps. And there's more muscles that you think about, like if you were just imagine this was your shoulder, same idea as rotator cuff, right? So it's a ball socket joint. You have 4 rotator cuff tendons. Their job is to hold it in the socket. But if there's an imbalance in one of those tendons, it's going to rotate one direction over the other because one is weak, or we overuse other ones, or there's damage. The list goes on, but you get the idea. Hopefully you get the idea. All right, let's put you down and we'll talk about correction of that. And we'll repeat all these ideas. I'm just trying to get you the picture here. Might show you one of my muscle charts before we do that, just so you can get the visual and the idea. And as far as rehab, there's no special exercise. I kind of left this out here so you'd see it. The idea of, Dr. Aaron, he's from Squat University. Shout out to Jeremy for giving me this book. The whole idea is you're lifting and you're using whole body motions to fix problems. What we do on the everyday. So breathing, big movement we do. And it's a big movement that's built into our deadlift and our squat, which we're going to talk about. Because they're movements we use a lot. We bend 4,000 times a day. We breathe 20,000 to 30,000 times a day, depending on how fast you breathe. So a lot of bending, a lot of hinging. It should be actually hinging. Should be some squatting, kind of all tie those together. Let's flip this chart around. Bled through a little bit, but I was expecting such shenanigans. Gotta brush up on my art skills. All right, let's look at the muscle chart one more time. As we mentioned that psoas, we kind of pictured it. Let's see, right there, you can see it off to the left. Oh, it's almost like the armchair of the pelvic, for the uterus. The uterus is sitting on the pelvic floor. We had those ligaments that get cut, and we have this psoas, iliacus and psoas muscle, which are kind of like the chairs that sit on either side of it. They run down the spine. Iliacus we'll talk a lot about because they do different motions. They're always, spoken of as they do the same thing. They're hip flexors. Not really. They're stabilizers of the lumbopelvic region. And we'll talk about where they attach and why it's important and how it can combat what that obturator internus and piriformis muscle are doing to the pelvic floor and how they're involved with breathing. Let's get you another picture of that psoas so you can kind of see it. There we go. As you can see, I wraps it down. Whoa. Need 3 hands here. Attaches right there, my thumb is. That's what we call the lesser trochanter. So the greater trochanter is where the piriformis, obturator internus attached. On the back side is the front side. It attaches more front. So you can think of it like the other end of the rotator cuff muscle, where it's pulling that hip into the socket, holding it so it's not rotating one over the way over the other. But you also probably notice that that psoas muscle at least goes up to where your diaphragm is. So yes, it is involved with breathing and stabilizing. And you can see how close it is to that uterus area and the pelvic floor. to the fun parts, exercises. But let's talk about breathing first. Yes, 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 more drawing, I know. Actually, we'll do it first. We'll do it first, and then we'll make sure we got Phil on the camera here. And then we'll break it down. Give you a break from Dr. Klein's terrible drawings. Let's make sure this doesn't fall. Can we see the ground? Need more light. All right. Should be good though, right there. All right. So use a kettlebell as a demonstration here. So first off, like getting the kettlebell off the ground, I already cheated, you didn't see me do it, but we want to get this hinge where the hips are drawing back. And I'm using those hips, using my psoas to pull the hips back. I talked about that pubic bone before, right here on Phil. Always want to kind of rest forward. So when we take a breath in, what'll happen is the hips turn out. These pelvic bones pull away from the sacrum, and the sacrum will tuck. Like a dog tucking its tail, that's counter nutation, it's the fancy word. So all three of those things happen at once on the inhale, generally. So I'm not thinking about it, just inhale. I can feel it. If I can really focus on those, I can feel it. And on the exhale, should be the opposite, where psoas kind of pulls in. We get that forced closure. Credit to you guys who made it through that other PowerPoint of forced closure, because we'll talk about that thoracolumbar fascia and how it covers the sacrum, all those big lat muscles, erector muscles, everything attaches into it. It gets tight and it forces that inhaled position. And we can also think about that pelvic bone shooting forward, because we're not like Phil here where we're straight all the time. Most of us have that pelvic bone forward. So the weight, we're going to put it right there. So if you have a dumbbell or anything, or just go buy a kettlebell, because kettlebells are awesome. So I'm going to lift this guy up again, hold it right there. So I'm just resting right against my pubic bone. And what I want to attempt to do is not do this on the inhale, but I'm going to get a big chest and I'll pull my pubic bone away. Inhale, let it out. Try it this way. Just hold your pubic bone there. Inhale. Where'd you feel the breath that time? Try it one more time. Pull the pubic bone away from the weight. It's not touching. It might look like it's touching. I've pulled it away, but I've also kept my ear, shoulder, and hip in a straight line. Where do you feel that pressure? Do the wrong way one more time. Where do you feel the pressure? So now we'll draw that out, and then we'll get to some more exercises. Okay, again, we'll do red for muscle. All right. So we're going to repeat everything we just talked about. So diaphragm is becoming important here. And we have the pelvic floor attaching to apex of sacrum, and this little dot is the pubic symphysis. That's this guy. All right, so just holds the pelvis and the front together, so that's where your pubic bones are, and then we have the attachment of the pelvic floor on the inside there, just so we can understand what we're seeing here in red. So the first breath, the bad breath, not that inhales are bad, it's just what typically happens is just some of us are stuck in this pattern. So we have this shortening, right, of this thoracolumbar fascia. So here's your spine. Let's draw that and blow. Need more hands. If you'd like to apply for a camera job, I can't pay you. I'll adjust you though. How about that? I will say, all right, so spine in blue, just so we can see this guy here. So we got that lumbar spine, thoracic, he's probably a little kyphotic, and a little cervical spine there. So the pelvic bone, or sorry, the sacrum bone is pulling forward, it's counter nutating. We have a hip drawn here to show that it's externally rotating. And we don't have an ilium on here, but those are pulling apart, they're gapping a little bit. And where's the pressure going to be? Kind of drew it faintly in pencil so you can cheat. It's going to be back here. So maybe you felt that. Maybe you felt that, but probably more what you felt is this arrow. More engagement, posterior pelvic floor muscles. So we get the pressure coming down when you inhale, and then pelvic floor is responding because it's also a diaphragm. It's driving the pressure, what? Into your belly. So the pelvic floor is shifting forward, and maybe you even have like a six-pack. I'm not saying that your abs are weak. It's just showing that that breath is being driven through the abdominal wall, which is causing further the shortening here. We should have felt pretty much the opposite of that if we pull that pelvic floor, or sorry, pull that pelvic bone back on the inhale. We're going to feel more pressure here, more engagement. Actually, where because remember in the front is urethra, vaginal opening where the uterus attaches, and then the rectum, all right there. So if you're sneezing and you're wetting your pants a little bit, probably the anterior is weak, right? Because we're getting more engagement in the posterior pelvic floor, the back of the pelvic floor, probably in our typical stance and our typical breath. You're like, well, it's breathing. Remember, 20, 30,000 times a day. It's the most repetitive exercise you do. All right, back over here. So if you think about pulling that pelvic floor back, we're going to engage more anterior, and you might notice the breath is actually driven back here. Not that's how it should be all the time. It's just we need to over-exaggerate our normal breath to retrain ourselves, right? We're working our body the opposite direction to bring balance. So that's going to take that same pen switch, take that same thoracolumbar fascia, instead of constricting it, it's going to, maybe that's what you felt. Maybe you felt that stretch on that breath. And we'll repeat all that, but here's the beautiful visual. So it actually requires some anterior engagement. The pelvic floor, or sorry, the muscles were destabilized. The anterior chain is destabilized because of the surgery. And most of us, because we're lazy, we don't engage like we should. And we get these same imbalances. And now we've lost ligament and structures, and now the muscles are being relied on more. The joints have failed us. A lot of us have this anyways. We get arthritis, but the joints have failed us. They've given all they can, and now suddenly your muscles are forced to do the work. And we'll show that postural pattern right now. So when we back the camera up here, get another light on. I don't know if that'll help. It's dark and gloomy in Pennsylvania, but at least we get rain. I know you're all jealous over there in Colorado. Maybe I'll edit this in post, but it's fun. You get to see me get my exercise in by running around. All right, make sure we can see everything here. Get the mat in view. We'll get Billie Jean over there. And we'll go over breath, we'll go over the deadlift, we'll go over squat, and we'll go over how complicated this all is and how you need to be doing foundation training, because that's going to retrain you to move better. I fear this camera's going to fall over, but I'll do my best. So let's get the weight up in a different way today. And before I do that, I need some coffee. All right, we'll review the breath without the weight. So think about everything we just talked about. We had the weight here before. So I'm taking my pelvic floor, or taking my pubic bone, I'm pulling it back. That's that psoas engagement. It's actually attaching, remember, here to the lesser trochanter, pulling the hips in. You watch my thumbs, they're rotating in as the pelvic floor draws back. I did a video on the kettlebell position, which I'll probably do right now anyways. We get it up in the rack position, a lot of us, we shove that pubic bone forward. I keep wanting to say pelvic floor, but it's pubic bone. Same idea. Instead of keeping that back and letting the hips go forward. So I've kept those hips turned in, then the knees are doing the work. That's a great knees over toe exercise. It's trying to take a lot of what foundation teaches about doing that, and then allowing the knees to pull forward. So you're actually resting on those hips. We have good psoas engagement. The pubic bone is actually pulled back. So when I first started doing more like kettlebell stuff, I'm like, well, that's terrible. It's a terrible position, because it looks like the pelvic. And when I first started, it was like really jammed up. jamming that lower lumbar sacrum joint, and hips are turned out. We have all those problems that we had in the inhale. Then we're inhaling, we're creating more opening of the SI joints, more turning of the hips, more shoving of that pubic bone forward, and then we're trying to go overhead with it. So we're starting from an unstable position. But if we open up that joint, turn in, it's a much better position. And we're getting rid of all that tightness in the mid-back. A lot of this stuff will actually fix your back pain, so I like kettlebells. So let's show you what that looks like with a kettlebell. And I've been doing these little routines. I've been working with people who are new to kettlebells, so I do like a little warm-up with them, just how to pick up the weight, how to move through the swing. If you've just had surgery, you probably don't want to be doing this, but a little bit of weight, a little bit of practice, you're probably running around, bending. If you can bend and pick stuff off the ground, if you can squat and pick stuff off the ground, you can work on these mechanics because they're going to slowly build up over time. But if they hurt, we'll run you through what to do as well. Work your way into them. But for now, let's just try this. I'm going to get a little wide. Got the kettlebell maybe 2 feet in front of me. So remember, we're not doing a hip thrust or drawing the hips back. As the hips draw back, hips roll in. I'm squeezing the earth. Some people like to think about tearing the earth apart. I notice either way, kind of good. I'm going to reach with one hand. So what I'm going to do is I'm just going to swing this and then place it down. So swung, and I brought it back down. So the hips are drawing back, but I'm keeping that pubic bone back as I'm swinging. Then I'm reaching to place the bell again. I'll show you with the other hand. Swing to ground motion. I'm not funking it down. I'm trying to be really light with it. And then you can work the breath in as well. Inhaling, exhaling. Whole body motion, hinging. I'm getting a lot of work standing a little bit. Hips are doing pretty much everything. I'm not letting them rotate out. I'm testing them. I'm pulling them in. I'm loading them, and I'm making them work through that position without letting everything collapse and compress. Once you get good at that, you can take that into other positions. Like maybe I'm just going to do a single arm deadlift, but maybe start with both hands to get good at it. Both hands are hinging back. Straighten those knees as best you can. More of a Romanian style. Just unlocked in the knees. We'll go into the squat later. Pulling those hips back. Place that bell down. Maybe you're not going all the way. Maybe you're just, okay, I'm just gonna go mid-thigh. Pull back up, root your feet into the ground. Inhale again. Maybe bring that bell to about knee height. Come back up. Go a little farther. Training the breath the whole way. And let's put that down. So there's good accessory muscles and there are bad accessory muscles. When we expand on the breath and we're getting more breath back here, we're using serratus anterior, serratus posterior, putting a stretch on that thoracolumbar fascia, which decompresses our joints, opens us up and prepares us for handling weight. You're like, well, I'm not really handling that much weight all day. This is only 35 pounds. I know you're picking up more than 35 pounds. Some women's purses weigh more than 35 pounds. It's all weight and it all needs to be treated carefully with respect. Not saying you have to do strict deadlifts every time you pick something up, but the more you practice these motions unconsciously, you're going to form better habits and patterns. I pointed the wrong words as I touched them. Okay, so let's review. We talked about getting that pubic bone back with breathing. Talked about getting that kettlebell off the ground, getting into the swing. Eventually it'll turn into exercises that look more like this. So I practiced here, and then I'm practice swinging. I'm thrusting, I'm drawing back, I'm thrusting, I'm drawing back. Go to the hand, hit Billie Jean with my kettlebell, and then you're practicing going into that rack position we talked about. where the pubic bone is drawing back and the hips are turning in. I'm engaged. And then you go overhead with it. But we don't want to go right there now. We want to work on hinging, which is our deadlift, and then squatting, which is a hinge. So lastly, we'll go over that squat, but remember to breathe. So we'll take it from the floor. Let's go a little wider, and I'll turn my position. So I'm wide, walk up to that bell. What we want to do is draw the hips back. But first, get the pubic bone back. A lot of people just want to start right away. They draw back, but actually extends the spine. And I can still feel that pubic bone is dropped forward, which is improper engagement on the pelvic floor. If I draw that back and I set the hips turned in, that's our little subtle anchor, right? Where the hips are turning in. I might even feel, just in this position, I feel those muscles we pointed to, that piriformis, obturator internus being stretched, because they want to turn the hips out, and we're not allowing them. In fact, we're pulling against them, retraining them, teaching them where they belong. Let's take this into a squat now. So as the hips draw back, we've set up that position. You can karate chop those back. The knees push forward at the same time. So maybe just do that slightly. Hips draw back, knees go forward. Maybe just a little one. Bring your hands back to your hips, straight from the side. So I'm not going fully knees, because if I go fully knees and less hip, I'm end up here. And we don't want to go super strict hip hinge, right? It's the knees going forward as the hip draws back, and you should feel it. Actually, a lot of these exercises you should feel mid-hamstring, because that sit bone is where your hamstring attaches, runs down to your knee. And if that pelvis is tucking, knees are doing all the work, that's when we compress. So we want to find that stretch in the mid-belly of the hamstring. So I'm feet turned out maybe just a little bit. That's okay if the feet are turned out. We can still turn those hips in, activate, squeeze that floor or tear it apart. That's what we call an inward anchor, an outward anchor. Either one kind of works with this idea. What essentially should be happening is the hips are turning in as the knees are driving out. If you notice your knees kind of do this number and your feet kind of roll off the outside, that's not a great squat, right? And you can see what my spine is doing. It doesn't look very pretty. That's why you should keep the knees out, but at the same time, don't lose your grip on the ground. I think that's a good cue from Squat University. So if either of those ideas of outward, inward help you, like I'll try tearing the mat apart. That gets my knees out, at the same time pulling that pubic bone back, maybe a little deeper with the squat. I'm more upright, my chest is upright. I feel it in my hips, not too much in my knees. I'm still using the quad. When you're doing just your general straight leg deadlift, you're gonna feel more, hip muscle stretch, hamstring stretch. You're getting a little bit of that, but now we're letting the knees do what they wanna do, drive forward, but we're keeping them controlled by the hip drawing back. So let's see if we can take it to the weight without bashing my head off here. Pulling back, knees going forward. Got that weight. Weight helps you, because then you can come up. Keep those knees driven out. Hips back. Lightly tap. Maybe you're just here. Maybe just a little bit. And then back up. Just a little bit. Back up. Remember to breathe. We're inhaling to stabilize. That breath is trying to bring it back or wide. Expanding width in the rib cage, into the back of the spine, not driving the belly out. Some people hold the breath to the very end, let it out, because they want to keep that expansion. Expansion is stability, especially as the weight gets heavier. Inhale, fill up this cylinder to protect it for when I'm moving. So you can do the same thing. And a lot of times your body you'll do that naturally when you're in pain. Some people notice they walk around, they're all suddenly all hip motion. They're all really stiff because this is all locked up and either damaged or arthritic. So they're suddenly, oh, I have a disc injury. It shows you how much hip motion you really have, which is always surprising. So, oh, I thought I had great mobility until you have an injury like that. So when we move under injury, it's actually showing us where our mobility is at. A lot of people, when I'm working, they'll see me, squatting or hinging, and like, oh, you must be in worse pain than I am. No, I'm trying to get my motions in because I know what it's like to be in chronic pain. So I'm like, all right, I know there's a pen there on the floor. It takes me a quick idea. That's how someone in pain might move, because they've lost the ability to bend. That flexion and extension of the spine, they've lost it. If we pattern ourselves to use less spine bending, more hip motion, that's going to help. It's going to help stabilize. It's going to help the breath be more pelvic floor strengthening in that anterior region, bring more tone there, but also addressing hip issues. And I said before, maybe one hip over the other. That's when you want to do the same exercises, but maybe do one-handed. That's why I like the kettlebell. I kind of did it already. Actually, I don't think I did. So after you've done a few, you've built up, you got the good feel for it. Put that bell mid-foot, hopefully you can see there. And now I'm going to kind of hinge back. The hand-to-hand swing kind of does this, but just one-arm deadlift is also nice. You'll really feel it in that one hip over the other. So I'm reaching down, pulling up. I'm feeling that left hip, but I'm also feeling all this fascia all the way up. Then switch sides. Do maybe 2 or 3 on one side. Breath in. Hip hinge, both hips back, but you're kind of loading that right a little bit more. And the left is actually doing something too. It's working to stabilize. For me, a lot harder here. I'm feeling a major difference. With my left hand reaching for the bell, this felt more comfortable because it's a little bit of twist in the spine, but it's also loading one hip over the other. So it tells me what I need to do is left hand dominant, do a few extra sets on that, and that'll take care of that torsion that's happening as well. A lot of us just start both hands on the bell, get the motion, get the rehab going, then try one-sided, work on that. Same thing with the squat. You can do that same thing, get a little wider, drive out, come up, or you could have the bell maybe in one hand like this. You're still kind of loading one joint over the other in that rack position. Switch it up, see how it feels. That actually feels a lot more comfortable. Tells me that my right hip probably isn't hinging as well. Hopefully that helps, guys. That was a lot of stuff. Breath, work on the breath. Build the breath. You can do it all day for every motion. Work on your deadlift throughout the day. You're going to pick something up, work on hinging, getting that object up. Then build into your squat. Chest is up, hips drop, knees drive forward. Pick your objects up. Start adding weight. Sometimes weight helps. Gauge the pelvic floor. We're not dropping down fast either. So all those motions are slow and controlled. That's more stability. If you just got the weight and you're kind of bouncing out of it, I just relied on all my ligaments to just kind of rebound. That pelvic floor is just kind of dumping out and then having to pop back up. Same thing it does on the inhale, right? It kind of expands, gets pressed down. Levator ani, because it's elevating, right? It's pushing back up. When it engages, that's its motion. When it's contracting, is to drive up. So it's constantly being pushed down by breath or your exercise. Maybe you're just doing a lot of CrossFit and you're trying to get high numbers in. So you notice, well, it's easier if I get that in the rack position and just bounce out of it. That pelvic floor never had a chance to actually engage and get some tone. So that's why it's sometimes good to do like those 1 1/4 squats. You're down, you come up a little bit, go back down. That's going to help train that pelvic floor. You can do the same concept here with the kettlebell if you got nothing else. Pay attention to that mid hamstring. That's going to guide you. It's going to be a good guide that you know that your hinging motions are working well if you got that stretch right there in the belly. Not so much in the knee. If you feel a lot of pressure in your knees are probably doing too much work. They're doing too much forward motion. hips aren't doing enough backward motion to counterbalance. What do you think, Billie Jean? How'd we do? It was really complicated and annoying. Yeah, I thought so too. But you look good with your sideways hat. All right, so Squat University, check out him on Instagram. Really good stuff. Foundation training, really good stuff. Go to the fix. You really talk about what I can do for you. That's like probably a whole other video, so maybe we'll segue into that one. There's a lot your chiropractors can do as far as working those muscles which attach to the pelvic floor. But ultimately, it's on you to retrain. But it helps someone to loosen up what's tight, and much easier to activate what's weak when we remove those restrictions, whether it's a muscle that's tight or it's a joint that's restricted, not moving as it should. But you still need the rehab, and the rehab is full body motions, retraining yourself for the movements you do all day, every day. All right. Questions, comments, griping, want to schedule, go to the npafix.com. If you like these videos, you want to continue supporting me, you can go to somewhere on there. I don't know if it's the plans. Yes, go to plans. There's a Fix Live. Get enough people signing up for that. That membership is just $5 a month. It supports me and these videos that I make. But eventually, if we get a couple people interested, and I'm just saying like 3 or 4, I'll start doing a class once a week. Just me and you. I'll have you in my headset. We'll be able to communicate, can ask me questions. We'll run through some exercises. It'll be great and glorious, and you'll have lots of fun, and you'll learn stuff. Versus this format, which I can't really see what you're saying. Maybe I'll do that right now. I'll flip you around. And it's annoying to type questions and all that. Thanks for sharing. All right, guys. Say goodbye to the pictures. Say goodbye to Billie Jean. You can be Billy Bones again.